was Vice President of Grand Rounds per Dr. Abrahamian. It's a very envious job title, to be sure. But so it's my pleasure to introduce our speaker this morning, Dr. Ranch, who luckily should be well known to most of us, so should make my job pretty easy. But Dr. Ranch began his education out at UCLA, and then I did not realize, but went all the way to Bangkok, Thailand, got his medical degree, came back and did most of his training in Las Vegas, Nevada at the University of Nevada, and then did a pediatric nephrology fellowship at UCSF. And since 2010, we have been honored to have him as part of the staff here. He's listed as a co-investigator on a number of grants with titles that are very long and frankly over my head, but clearly has been productive and is talking to us about a arguably very challenging topic, as I'm sure all the parents of teenagers in the audience will agree, and that is the teenage transplant patient. Thank you, Dr. Ranch.
Thank you. Do we need to get the lights? Is there a switch? Oh, okay. Magic. Okay. Can everybody hear okay? All right, if you can't, please let me know. Thank you for a very nice introduction. I don't know about the honor part of being here since 2010, but I've been honored to have been here for that long. And like Colleen said, we'll be talking about a rather interesting topic today. I'm sure that's always on all of our minds as transplant professionals. I do not have any financial relationships to disclose, and as a pediatrician, I probably never will. Just a quick overview of our team, actually. Because actually I don't get to cross over to the adult side too often. Some of my other colleagues may do more frequently. But once again, my name is Danny Ranch. I'm one of the nephrologists. I've been here for 5 years. Our chief is Dr. R, sitting in the front row. And we also have Dr. Yamaguchi, who joined us last year. We have a dedicated dietitian, Lori, our relatively new pediatric transplant director, Adesawa, and our transplant coordinators, pharmacists, social worker, and office and clinic staff. And hopefully I didn't forget anybody. A brief overview on pediatric ESRD, since I'm sure you guys aren't thinking about our data every day. The Texas pediatric population is about 7 million kids, and I believe we're second only to California. And the prevalent pediatric dialysis population probably sits between about 200 and 300 each year, depending on how many transplants the centers do. But you can see a much smaller population compared to the adult folks. Okay. And in kids, you'll notice that their causes of kidney failure are much different from the adults as well. Whereas in adults, you typically have your diabetics, hypertensives, and also predominant polycystic kidney disease. In kids, we see mostly congenital anomalies as their cause of kidney failure, urinary obstruction, and then you start to get to glomerular diseases like focal segmental glomerulosclerosis. This is one of our prior transplant patients here. Looking at numbers, you can see that in the US, the past couple of years, there have been about 700 or so pediatric kidney transplants each year. California has done the most, obviously because they have the most children, followed by Texas and then New York. And then looking at state level data, I've actually been very proud of our center's activity and our outcomes. If you look at from a volume standpoint, we're right up there with the other larger centers, not only in the state, but also in the country. And so I applaud our team for the great work they've done in terms of marketing and recruitment. So all right, to actually get to the topic we'll be talking about. And unfortunately, adolescent transplant outcomes and how not good they are have become synonymous with, just like maybe tissue paper and Kleenex. For some reason, everyone seems to know that teenagers equal bad. And you can't really blame them because there's a lot of data out there to show that. Here's one example in this study from the early 2000s, analyzing the NAPRTIX database, which is a database starting in the 1980s on pediatric transplant. By that time, they had studied about 6,700 transplants, and they found, as expected, at the adolescent age group had the worst graft survival compared to their other age groups. Looking at their 5-year living donor graft survival data, 77.3% for teenagers, less than your toddlers and school age, and even your infants. And then for your 5-year cadaveric donor graft survival, also you saw the same thing, lower graft survival compared to the other two groups, although higher than your infants. And they believe that the main reason for these worse outcomes in adolescents were medication non-adherence and late rejection. As for the infants, they noticed that it was like mostly early graft complications, either technical or early rejection, that resulted in a much steeper slope in the first year for these infants. But if you look over time, the slope of their survival curves actually ends up matching the adolescents. Otherwise, show that teenagers don't do well long term. Similarly, in this review of data from UNOS in the late 80s to the 1990s, approximately 9,000 transplants, they found similar findings where you can see that 1 and 5 year graft survival, actually, I take that back. 1 year graft survival for teenagers was actually better and then worsened over time, and also with lower projected half-lives. And they also believe that this was due to medication non-adherence and late rejection. This more recent review of SRTR data from 2012, and I actually liked how they presented this. They analyzed obtained data, about 36,000 kidney transplants, and their rationale was to show that not only were adolescents doing worse compared to other pediatric age groups, but also they were worse to basically every other age group in the transplant world except for the more extremes of age with greater than 70-year-old age group. And as you can see here, 1 year graft survivals are good, but at 5 years there's a sharp drop by age of transplant here in this group. Despite these patients getting, at the time we believe to be the ideal kidneys through Share 35. And once again, they found that likely the worst outcomes in the adolescent age group due to non-adherence and rejection. Excuse me. And then to continue the teenage bashing, in this study from the OPTN data, about 160,000 kidney transplants, first-time transplants by this time, showed similar findings once again with worsening graft survival over time, depending on age at transplant, with adolescents performing the worst. So they had, once again, the worst long-term graft survival and shortest graft half-lives. Interestingly, they also showed a difference in outcomes depending on their insurance coverage, where patients with private insurance did much better than patients with government insurance. But otherwise, just adding to the pot that adolescent transplants don't do as well. And I know I'm picking on kidney patients, but actually this has been shown to be similar. The similar findings have been shown to be across all different organ groups. In this study from just this past year, looking at graft survival by age of transplant across kidney, liver, heart, and lung transplants. And they found that, once again, in the early phases, teenagers actually did well. Their survival was actually, 1 year survival was actually better than the other age groups. However, over time, these survival curves would cross over with adolescents showing longer-term worse graft survival. So it seems like maybe in the beginning we're doing something right, or giving them plenty of immune suppression to get them through the first year. But so what other factors might be contributing to the fact that they're doing well initially and then worse down the line? In this study out of UCLA from the 1990s, through patient reporting and monitoring of cyclosporin levels, they found that the range of reported non-adherence was between 5 and 50% in pediatric kidney transplant patients. And when they broke it down to just teenagers, actually, it could be as high as 64%, which is very alarming, right? And they also, to compare, adult non-adherence numbers, I believe, are less than 5%, probably 5% at most from reports. And they also reported the resultant negative effects of non-adherence on grafts, with patients either having rejection and decreased kidney function, or just losing their grafts. Similarly, in this study, assessing pediatric transplant patients' medication adherence, they also found that adolescents were more likely to be non-adherent compared to younger children. Excuse me. But they also found some other interesting findings that will lead me into other parts of the talk. So they found that a significant number of these patients had underlying problems that also affected their treatment, the biggest ones being underlying psychiatric diagnosis, with the most common being major depression and adjustment disorders. And a lot of times, we don't think about these conditions in our younger kids. And these underlying conditions were associated with adverse graft outcomes. What made me even more concerned, though, was when they surveyed or asked the parents why, or patients, why they weren't taking their meds, the top reasons were lack of parental supervision and parent-child conflict. So that makes me think that there's more going on than just teenager doesn't want to take their meds. So we probably have to dig a little bit deeper. And then this group, interviewing pediatric liver transplant patients to assess medication adherence, when they asked the patients, the most common reasons were either they didn't have a reason or they forgot. And I guess that's understandable, they're kids. But when they surveyed the parents, what is really concerning is you get the same answers. Either I don't know why my kids take their meds, or they're saying that the patient forgot. And it's probably not a good idea to have your 12 or 13-year-old taking their meds unaccompanied. So this should open our eyes to the fact that once again, there's a lot more going on behind the scenes that is affecting our patients' treatment. So some of the other reported factors factors reported in the literature that might affect how our patients can deal with their chronic illness. We found things such as how many medications they have to take can affect their adherence, cosmetic side effects, especially for patients, our young patients in high school, more doses during the day, inconvenient dosing, having to take a dose in the morning, because teenagers don't like to wake up early in the morning, right? Medication taste or difficulty swallowing. A lot of our patients, even at the older age, still have trouble just swallowing pills, which we as adults think might just be a routine thing. Their underlying disease-related factors, psych disorders. Some believe that patients who didn't have to go through the burden of dialysis, maybe didn't, quote unquote, learn their lesson. Socioeconomic factors, so minority groups, poor socioeconomic status, poor family structure, and all be related with poor outcomes with transplant or poor medication adherence, and then a lot of different patient factors, which I won't go through. But So to help us understand why teenagers don't do well with their treatments, why they won't just do what they're supposed to do or do what they're told, we have to understand their developmental changes that they're going through in addition to dealing with their chronic illness. Typically, adolescent development is broken down into 3 stages: early, mid, and late adolescence, and the different tasks they'll have to accomplish falls under the categories of biological changes, cognitive and psychosocial changes, and social tasks. In early adolescent development, biological changes include early puberty, and girls start to develop secondary sexual characteristics and breast buds. Boys start to have testicular enlargement. Under cognitive or psychological changes, these patients are still thinking pretty concretely. An example of that would be, I missed a couple of my asthma medication doses, but nothing bad happened, so I guess I don't need my meds anymore. So, also, they're starting to develop their sexual orientation and realizing that they actually have a body image and reassessing it. And then finally, social development. They're developing a need for privacy. That's why their doors are always closed and locked in their bedrooms. Identification with their peer group, and exploring and testing boundaries. So, mid-adolescence, you start to see girls hit mid to late puberty. Their growth spurt is done, and they're starting their menstrual cycles. In boys, it's the beginning of their growth spurt. You may notice that's when their voice starts to change. Under cognitive and psychological, they start to develop abstract thought, but still pretty simple compared to adults. A lot of times, even though they know what's right or wrong or what the best course of action is, their decision-making is still driven by emotions. And so that also affects, say whether I should take my meds this morning or not. And then they have this all too well-known sense of invincibility or invulnerability. Nothing bad can happen to them. And finally, under social development, they're still struggling to become more independent, have increased separation from parents. I don't have kids, so I haven't had to experience that. And really identifying with their peers. And finally, in late adolescence, puberty is done in boys. You see an increase in lean muscle mass. They finally start to develop complex abstract thinking, with the example of that being, I missed a couple of my asthma medication doses and nothing bad happened, but probably because I wasn't exercising at the time. And if I want to continue to be able to exercise, I need my asthma medication. So, they also have increased impulse control and better assessment of risk versus reward decision making. And finally, under social, still developing more autonomy. They start to value their peers and how important it is to be like them less, and they start to form stable relationships. And actually, we know now that neuromaturation, the brain, doesn't just magically stop at 18 years of age. It actually continues on into relatively late in life, into the third decade. And they found through advancing imaging technologies that kind of more primitive functions like vision, hearing, sensory motor develop earlier. And the areas associated with more complex functions like abstract thought, impulse control, emotion control, which are the frontal lobes and prefrontal cortex, those actually develop last, well into the 20s. So there's actually a biological basis for why our teenagers are, we might think our teenagers are crazy. They just can't control it yet. So, so once again, can't blame them all completely. It's not all their fault. And so going through all of that development, change and raging hormone levels, you add on top of that some type of chronic illness that affects their normal life schedule, you imagine you can cause a lot of trouble. Some of the things that can be disrupted in terms of psychological adjustment, so they'll develop behavioral emotional problems. I'd say most, if not all, of my patients have low self-esteem. Get a lot of complaints about sleep. They can't sleep well. And teenagers, they need to sleep, right? Especially to grow. Effects on social tasks include poor growth and development. They may be unwilling to identify with peers because they're quote unquote sick or taking medications while their friends are out doing normal activities. And school adjustment, a lot of our patients miss a lot of school or end up dropping out, end up in being homeschooled because they're either too tired from their disease or they just don't want to go to school. In this study on young adults with chronic kidney disease, children, adolescent, young adults, they compared neurocognitive performance testing in patients aged 8 to 25 years old with healthy controls, and they found that patients with chronic kidney disease performed significantly lower in many different areas, including attention, both verbal and working memory, visual spatial, meaning being able to learn by looking at images versus words, and inhibitory control. And I believe that there's a lot of good data, similar data in the adult CKD population as well. Okay. And they also found significantly lower performance with lower kidney function, worse kidney function, and actually worse blood pressure control too. And so these problems, they don't just go away magically. They're persistent in our patients, even when they're being prepared for transplant. And this group looked at academic, where'd it go? Looked at academic performance in pediatric patients undergoing pre-transplant evaluation for either kidney, liver, or heart transplant. And they found that intellectual and academic performance was worse across the board compared to healthy controls and in all organ transplant groups. So once again, this should help us as healthcare providers to understand that and realize that we can't always expect our kids with chronic illness to perform tasks as well as your healthy teens. Oops, there we go. All right. And these problems don't just go away when our adolescents reach adult age either. There's no magic that happens once they hit that special age of 18 years. And if anything, poor medication or treatment adherence has been shown to predict future poor performance. And I put this up because, personally, I like the title. This was a study out of the Netherlands in young adult kidney transplant patients. They were surveyed on their perceived health status and well-being. And the researchers found that the patient's self-medication reported adherence was significantly higher than their actual medication adherence as measured by their tool. So even in young adults, at this age, they're still doing the same things they were doing as teenagers. And they also found that transplant patients' self-reported subjective well-being was higher than in healthy controls, thus the title of the paper. And it makes me laugh because it's a pretty accurate description of our teenage transplant patients. They feel better because they have their transplant, they're happy to be off dialysis, and since they feel better, they don't need to take their medication because they want to be normal again. But this helps illustrate that some of the identified problems related to poor transplant outcomes in teenagers don't just disappear with time. We actually have to work with these chronically ill kids to help them catch up in their journey towards becoming an adult. So now that we know that the fixes will have to start early before transplant and continue long after, what are some of the barriers and strategies in the preparation of these patients? Well, a lot of our adult colleagues would still say, don't transplant teenagers, right? We give them this precious resource, give them an organ, and then they basically throw it away. So why waste it? But unfortunately, once again, we have to help save them from themselves in a different way. And if you look, and this is a well-known data from USRDS, end-stage renal disease data, we know that transplant offers the best long-term survival in our kids compared to your dialysis modalities, with hemodialysis being the worst. There's some skewing of this data because they include young infants in this survival curve as well, and that really brings it down. But still, transplant offers the best survival. And even in adult patients with kidney failure, you can see that mortality is much higher in patients on chronic dialysis compared to transplant. So we have to keep trying. What else can we do? Well, trying to improve their transition process into adulthood. Hopefully will improve those outcomes overall. And some of the barriers that have been identified include medication adherence, the underlying medical issues, improving the transition process itself, including patient readiness and timing of the transition process, and improving support from both the healthcare team and the parents. So addressing a parental anxiety, attitudes of the staff, insurance issues, and the cooperation between the healthcare teams. So in terms of improving medication adherence, it's found that some people believe that pre-transplant education and training for these patients may help. For a lot of our patients, actually, we will have them go through a period of adherence to their treatment. But the caveat to that is they have to have a really good support system. So without strong family structure and healthcare team as a backup to make sure, when they falter, that we're there to pick them up, they're not going to succeed. And so having that backup support system is really important. And then something as still lacking, unfortunately, in our team here is psychological counseling. Once again, as you saw from prior data, our patients with chronic illness, a lot of them have underlying psychological disorders, and we can't ignore those. In this study, they detected 3 different types of patient profiles in terms of non-adherence and some suggested interventions, including accidental, so patients just happen to be forgetful. They recommended using dose boxes, basically pill boxes, which we use, other age-appropriate medication cues, and trying to simplify their immunosuppression regimen, so trying to go to twice-a-day dosing versus 3 or 4 times a day for certain medications. Patients who don't take their meds because they feel invincible just need more indication. Some would say maybe a spanking, but really just astute education to help them to understand why they need their medications, and may help to have them interact with other peers in the transplant world so they can relate to them and understand why they need to take their medications. And finally, patients who are just oppositional and don't want to take their medications, education and psychiatric consultation would be important. Also, being able to recognize medication non-adherence early on is important so that we can tackle it right away. And they listed some characteristics associated with pediatric and adolescent non-adherence. Ignore the adolescent part, right? But once again, low self-esteem, underlying psychiatric problems, poor communication skills, or not understanding and not accepting of their diagnosis, But there are family characteristics as well that might be associated with high risk of medication non-adherence. So single-parent families or family instability, poor socioeconomic status, or poor home environment, all these things also can contribute to patients not wanting to take their meds. If we don't have a parent standing there watching them swallow their pills, more likely not, they're just going to leave them on the counter or throw them in the trash. And then some techniques that might help us to monitor our patients' adherence. Usual subjective techniques include self-reporting, reporting from third-party observations such as the parents themselves, friends, social workers. Had one parent who had her patient's younger sister watching her and reporting, and then examination to detect expected physical side effects of certain medications. And the advantage of this technique is that it's cheap, it's free, but it's not entirely reliable. So electronic monitoring using technology has been found to be likely the most accurate, but it's expensive. Not all centers or patients can afford those electronic pill boxes or whatnot to monitor their pill taking, and it's just not really practical. And finally, monitoring medication usage, so calling pharmacies to make sure that patients have actually refilled their medications, having them bring their meds and counting their pills in clinic, and drug level monitoring through a blood test, probably is the most practical and what we do most of the time. And it is relatively reliable, but you need a lot of support from the other staff to make sure that we can stay on that. And more general strategies. So I guess it's this first one, forming a relationship with your patient is easier for us in the pediatric world because we have 5 to 10 times as many, less patients than the adult folks have. We see our patients relatively frequently. We have time to actually sit down and talk to them when they come to their visit. So forming that bond may be easier for us as pediatric transplant professionals. But once again, more education. Our poor transplant coordinators probably educate these patients up the wazoo, and who knows how much actually sticks. Other behavioral strategies, once again, so trying to simplify the regimen. I'll always ask, if you're missing your morning medication, why are you missing it? And typical answers I'll get are, I'm late for school, or I'm distracted because I'm getting ready for school. So trying to find some other way, a better schedule for them would help them to stick to their regimen. More frequent clinic visits, we actually try that. Unfortunately, a lot of times they just don't show up. But still, once again, more closer monitoring, and maybe for some of these patients, which we actually already do, even though our protocols say 2-3 years out we don't need to see them so frequently, maybe sometimes we still do, just to help keep tabs until we can assess that they're mature enough to handle their treatment. And then a clinic environment. So our team actually secured some small funds from the UHS Foundation grant, and hoping to be able to have a teen space where when patients come for their transition training, which we'll talk about later, there'll be a friendly place for them to basically hang out with other peers while they're learning about taking care of themselves. Also, with our grant funds, we through the really hard work of Irma and Robin, to obtain these funds, we'll be purchasing iPods for all of our teenage transplant patients as part of their transition training, to be loaded with this app called the My Med Schedule app. So they'll always have their medication list with them in the. Still hear me? You guys still hear me? No? I think the battery ran out. You hear? No? Better? All right. So, yeah, no battery. Excuse me. So the medication list will always be available, and when our team makes changes online through Med-Action Plan, the changes will actually be automatically updated in the app. We can also send a reminder email that we made a change, send reminders to take your medications, and reminders to refill the medication. So we hope to get this up and running soon. And I don't have any relationship with this company, obviously. So I won't go through all these, but some of the consequences of their underlying disease. So a lot of our patients have poor growth because of their kidney failure, and so with shorter stature comes lower self-esteem. I know that from personal experience, but also psychosocial difficulties with adapting to their peers. Let's see. Diabetes. So actually we've seen a lot more diabetes pop up post-transplant. And so all of a sudden, in addition to their adolescent development, their transplant care, now they have to check their blood sugars 3-4 times a day and take insulin shots 4 times a day. So it really takes a toll on their psyche and how much they have to do, and just makes them regress even further. I'll skip the rest of these. So excuse me. People have always talked about the importance of having a transition program, not just for transplant, but for all kids with chronic illness. As far even in the early 2000s, I think they had meetings about it, and there was a consensus, and everybody agreed. But unfortunately, not much has been done about it overall. And then a few years ago, there was a collaboration, and they came up with a joint policy for developing guidelines for centers to develop what should be a successful healthcare transition program. And they came up with these 6 core elements of a successful healthcare transition program, and then they tested it early on to see if it would actually be beneficial. The 6 core elements that they developed included centers actually having a transition policy, right? A means to track and monitor our teenage patients' progress as they go through the transition process. A means to assess transition readiness and orientation to adult medicine. And then transition planning for integration into how adults care for kids, which is much different for how we care for them in our clinics. Planning the eventual transfer of care, and hopefully being able to have an initial visit with their future providers. And then finally, plan for their completion of their transfer and their ongoing care. So. And what they learned from this collaboration was that implementing these 6 core elements was feasible with the tools that could be developed. They found that involvement of all the healthcare teams, pediatrics, family medicine, and the adult providers was key, and we know that. They also found that support from senior leadership, I saw Jennifer walk in, was essential. Sorry, I put you on the spot. And starting earlier rather than later would make it easier for us to transition our patients. And then for me, really having dedicated transition support staff, meaning nurses, coordinators, social workers, and other staff is really critical for having a successful program. So some strategies to improve transition for the patient themselves. You can see it was getting late. There's much more cut and paste here. Preparing the child to be responsible for their own healthcare. So just gradually getting them to understand what their disease is and why they're doing the things they need to do. I think this is a big one, which maybe we don't do as good of a job as we should. Encouraging school attendance to get them back on their normal life track and understand that they can have a normal life, especially after transplant, as long as they do certain things like take their meds. Psychological concerns should be addressed as soon as possible. And once again, if we hopefully in the future have better psychological support, we can improve that. And then some basically goals or critical milestones we believe that should be achieved with patients' transition readiness training include making sure they understand once again what their disease process is, why they have a transplant, what they need to do to keep their transplant working, being aware of the short and long-term implications of having a transplant. This we probably don't talk about at all, is understanding the impact of illness on sexuality and reproductive health. As non-general pediatricians, we are really good at skipping over that topic, but we should be doing a better job of addressing it because it's a significant source of stress on these patients. Getting them to demonstrate that they can take care of themselves, be responsible for their own health. And also, sometimes patients don't want to move on, and we try to push them out, but we have to work to get them ready for them themselves to want to move on to adulthood. Okay, so, And I forgot to put this in my talk actually, tools so that they'll be able to have their medical history in a portable format. So when they go to other providers or go to the ER for a reason, all the information will be there. So there are many different transition tools out there, but Dr. Maria Ferris out of UNC has done a lot of great work in this field, and we've been using her tools so far to help our patients get ready with transition. One of her tools is the UNC Transition Scale, and transition is an abbreviation for type of illness, RX is for medications, adherence, nutrition, self-management, informed reproduction, trade, school, or basic education, insurance, ongoing support, and new health providers. And so the scale, which is administered by the healthcare team, it only takes a few minutes, measures healthcare transition and self-management skills in these kids with chronic ill conditions. So it's not disease specific, it can be used with kids with any chronic illness. And then they have a guide in terms of assessing their score. And what we hope to see is that the score improves over time, and that hopefully correlates with transition readiness. And it's still relatively early, so we don't know, is there a score cutoff where patients actually are, once they hit the score, they're ready for transition, or how much progress they need to make? That is still in progress. The tool is available online, although the tool itself is actually paper-based right now, and it's available in Spanish too, actually. Also, they developed something called the STAR questionnaire. Basically, it's a self-administered exam, takes once again just a few minutes, and it tests them on their medication management, assessment, provider communication, engagement during appointments, their disease knowledge, their health responsibilities, and utilization of different resources like our social worker. And also it's available online, but it's still a paper-based questionnaire as well, but they should be moving to an online module real soon, and it's also available in Spanish. And this is just a screenshot of their website where their tools are and the information pages. And we like it. I think it's a great tool. Like I said, there are other tools out there, but we're using it, and I'm actually in the process of completing the IRB to be part of their multi-center study so that we can send them our data and hopefully not bring down their statistics too much. Ways to improve support from the caregivers, and this is echoed in other fields. Strong family in other fields in pediatrics, strong family support is really crucial. Kids can't function normally without good support from their parents or caretakers. And on the caretakers themselves, the child's illness, especially if they were sick early on and been on dialysis or had other complications, really takes a toll on them physically and emotionally. And a lot of times when we see them in clinic, we may forget about it or not recognize it. So, these patients' families a lot of times can't have normal family activities like vacations. Some of our patients can't even just drive to Houston for a weekend or something because maybe they're sick or they miss certain holidays or events because of their illness. And then, a lot of times our caregivers are so involved in the care of their child as they're grown up over the years, when it comes time to move on to the adult world, they really can't let go. And so some of the things that we can do to hopefully help improve this once again, including the child in their care so that they not only they understand, but the parents see that they understand what's going on with them and their health. We're not doing a good job of this one either, but we always push for our patients to have a primary care physician because once again, we're, as specialists, we may miss a lot of normal developmental or normal preventive medicine care items. And then including the family in the patient's choice in terms of where they're going to transition the child may also help so that not only will the patient develop a relationship with the adult provider, the parents will as well. Some suggested improvements for us as the pediatric healthcare team. Once again, having a transition policy would be a good start, and we do have that now. Let's see. I talked about most of these already. This is one that our social worker, Robin, does a great job of, and we probably, well, I take that back, I probably don't understand as well yet in terms of, what are the future financial implications for these patients. A lot of time, they turn 18, they're not done with high school yet, or maybe they happen to drop out of high school, they don't have a job, or don't have a job that has insurance. What are their options, what do they need to keep up on? I probably need to do a better job of counseling in that regard. All right, let's see. From the adult side, Dr. Stevens is stretched pretty thin, I hear, but hopefully we can prove that in the future. But yeah, having a dedicated adult provider would really be helpful, because once again, we'd have a go-to person. These patients would have something that they could identify with and develop a rapport with. We've tried in the past to collaborate, but because both, and this is common all across the country, is both practices are so busy that to be able to take another chunk out of someone's day or week to do this is very difficult. But we'll continue to work on it. I'm pretty sure my adult colleagues don't want any training in adolescent medicine. That's okay, neither do I. Once again, increasing clinic visit appointments, although that's going to be a burden on the providers because they already have 10 times as many patients that we see. Making sure that our patients have an adult primary care provider as their point person for coordinating care, because a lot of times our patients have other comorbidities that need to be addressed as well. Yeah, designated young adult transplant clinic day. That probably will not happen in the near future. Maybe a couple hour slot or something. But once again, it's going to be really important if we're going to have a successful transition program, is to have the adult providers on board. Some of the things that our program is doing now. Actually, we've been transitioning our patients, but we've been making our process more formal, once again, with the great work of the team here. We've made a list of patients who need to be transitioned. The younger ones, we'll put them on usual standard schedule. The ones who are closer to adult age, we'll try and fast track them. We've been using Dr. Ferris's STAR and transition scale testing to assess their transition readiness, and it helps us identify areas of weakness that we could hopefully work to improve. Our team is already doing transition education classes once or twice, at least once a year, maybe twice, where both the patients and their families come. And then our grant funds that we obtain for their iPods, so we can use that My Med Schedule app, hoping to have a teen room. Other things we hope to put in there are computers that they can use, an exercise bike or treadmill so they can actually exercise, and trying to promote good overall health as well. But some of the things we still need, at least in my eyes, you could really use a psychologist. Once again, it seems like underlying psychological problems is a larger and larger problem that we're recognizing in our patients with chronic illness. And if we can't succeed in improving that, it's going to be unlikely we're going to succeed in the transition overall. More child life support, because once again, these are still kids. Case manager to help with general other tasks that they'll need to take care of themselves. A dedicated pharmacist, and actually I'll commend our transplant pharmacists for being willing to come and meet our patients even when they're on dialysis or not transplanted yet, to help educate them. Once again, having dedicated adult providers that we can transition to and that our patients can develop a rapport with. Other possible roles that could be filled, having advanced practitioners to see a lot of these kids, and maybe in financial counseling, not only for their patients but for their parents as well, because having to pay for these medications or come to visits, pay for gas, it can take a toll on patients, especially when they're not as well off financially. And finally, so my future vision, as you can see that there are a lot of other chronic illnesses in kids that are being treated, and because of our improved treatment, they're actually making to adulthood, and then they go to their adult providers and everyone freaks out. So it's on all sides. So but you should look and see not only transplant, but our patients with diabetes, cystic fibrosis is a big one, patients with sickle cell disease, inflammatory bowel disease, our long-term cancer survivors. There's no good identified transition process yet, patients with asthma. So my vision is a multidisciplinary transition clinic, actually one space that could be used by any specialty, any patient with chronic illness. We'd be able to pool resources. So instead of our team has great social work support, their team has a psychologist, their team has a great pharmacist, we should be able to put it all together in one pot. And I think that would improve the care for all these patients. We'd be able to have standard protocols for transition and generally improve coordination of care. So, and I know that takes a lot of work from multiple sides, but I see that as the ideal answer to improving transition for our kids, so that there are less adult dialysis patients. And finally, I always have to put in my shameless plug. So I have a small investment in the field, having donated to my wife actually more than a few years ago now, but otherwise, thank you for listening.